Welcome to an online workshop presented by the Center for Health Economics of Treatment Interventions for Substance Use Disorder, HCV, and HIV. Today, we will talk about cost-benefit analysis. Cost-effectiveness analyses, cost-utility analyses, and cost-benefit analyses are all examples of a full economic evaluation, which means the analysis considers both the costs and consequences of a program, policy, or intervention, which is being compared to an alternative program, policy, or intervention, such as treatment as usual. These are the two critical components that qualify a study as a full economic evaluation: comparison of two or more alternatives and accounting for both the costs and consequences of the alternatives. If you want to understand resource allocation and value and focus on what is the most efficient use of resources as part of the decision-making process, you need a full economic evaluation. A cost-benefit analysis, or CBA, allows numerous program consequences to be considered, and in CBA, both costs and consequences are valued in monetary units, which helps you understand whether the program has a positive return on investment. By expressing costs and consequences in pecuniary terms, investigators can make direct comparisons between program costs and outcomes to estimate net benefits, sometimes referred to as cost savings or cost offsets. Cost-benefit analysis was traditionally considered broader in scope than cost-effectiveness analysis, as CBA incorporates multiple outcome domains into the analysis. Over time, this has shifted as the latest recommendations for standardizing cost-effectiveness analysis calls for inclusion of both the healthcare and societal perspectives. With CBA, we are concerned about the broadest societal perspective and selecting programs or policies that maximize social welfare. Translating the desired outcomes associated with a program or policy into dollars provides estimates of economic benefits, which can then be compared to the costs of implementing the program or policy to determine if the benefits outweigh the costs. Using a CBA, we want to inform questions about how best to allocate limited resources and whether these programs are worthwhile. A program may be cost-effective, but not necessarily worthwhile, because cost-effective is not the same as cost-saving. What goes into these costs and calculations? Well, it depends on the perspective of the analysis and what viewpoint you are taking. The results of a CBA are primarily a net social benefit, subtracting the cost of implementing a program from the benefits attributable to the program. If the net social benefit is greater than zero, then we show the program is a good value and cost saving for the analysis timeframe. Program costs and benefits can also be compared in the benefit-cost ratio by simply dividing economic benefits by program costs. If the ratio is greater than 1, the benefits outweigh the costs. Analytic differences in the components included in the numerator, the benefits, or denominator, the program costs, make benefit-cost ratios less comparable than estimates of net economic benefits. The challenge for the CBA is the valuation of health and related consequences in monetary terms, particularly when benefits come from disparate outcome domains and timeframes. Two key resources in these analyses are Drummond et al. And the second panel on cost effectiveness in health and medicine. There's a lot of overlap in the societal perspective of a cost effectiveness analysis and a cost benefit analysis, so they are both excellent resources for understanding the CBA methods. This is a useful schematic from the Drummond book because it lays out what you need to consider when approaching an economic evaluation. We think about four main areas of cost: the healthcare sector, cost to other sectors like criminal justice or education, patient and family costs, and productivity losses. These four bins are used to characterize the economic benefits on the consequences side as well. Here, we are thinking about the resources saved or reductions in costly outcomes, such as criminal activity, that translate into economic benefits of the program. This matches to the impact inventory in the second panel on cost effectiveness in health and medicine. Just another illustration of how we are broadening the cost effectiveness analyses framework to incorporate the societal perspective, thus creating an overlap with many elements included in a CBA. Traditionally, there are two approaches to estimating economic benefits. The first is contingent valuation, where stakeholders, or society as a whole, are surveyed about their willingness to pay for a desired outcome, such as gaining a quality adjusted life year. The payment would go towards treatment or policies that will generate this outcome. Willingness to pay estimates subsume individual outcome domains, as stakeholders are presumed to think broadly about the variety of benefits generated in defining their willingness to pay. Inherent in defining a willingness to pay, especially in healthcare, is thinking about how we value life. Here, we consider consequences and the impact in the four cost bins described earlier, and how an intervention might impact these bins. How do we value health and life? Well, there are three approaches: human capital approach, revealed preferences, and stated preferences of willingness to pay. The human capital approach relies upon productivity or earnings, so we use someone's wages to value an hour of their time. The benefits of extending life, therefore, are calculated as the present value of future earnings. Wages are accessible to monetize benefits, but there are limitations with how accurately wages represent the value of time, especially considering racial, ethnic, or social differences in earnings. For individuals who are not in the workforce, clearly their time is not worth zero. So sometimes we use the federal or state minimum wage as a proxy value, considered a lower bound, to impute a monetary value per hour. Revealed preference is based on using data reflecting decisions and choices people make mostly related to their health and safety. As an example, consider people accepting higher risk jobs for higher pay. Thinking about this trade-off of health and money will help us estimate the value of a statistical life, or VSL, sometimes referred to as the dollar value of a theoretical life. This is an example from Drummond et al., originally extracted from Fisher et al. In 1989. Suppose you are comparing two jobs, A and B, and they are identical, but job A has a higher risk of death than job B, and the people in job A earn $500 more per year than those in job B. Using the Jones-Lee approach gives the value of life of $5 million, because workers in job B are willing to forego these $500 a year to forego a 1 in 10,000 risk of mortality. This translates to value of statistical life, or VSL. Another important study in this area by Viscusi and Aldi was a comprehensive review and meta-analysis of several studies in this field and looked at wage risk trade-offs and types of morbidity risk premiums, such as investing in a home security system, and reported a median VSL of $6.7 million in 2000 USD. This is most useful for valuing marginal reductions in the risk of death attributable to a program, policy, or intervention as economic benefits. In the US, the practice of using VSL in policy evaluation is sanctioned by all federal agencies. As an example, the EPA recommends the use of a VSL of $7.4 million in 2006 dollars, which is similar to the result from Viscusi and Aldi, but there is no standard VSL for all federal agencies. Asking stakeholders directly what they are willing to pay for health or other outcomes resulting from a program, policy, or intervention can be used to calculate the economic benefits. In this approach, individuals are surveyed and presented with hypothetical scenarios about a program or problem, and they then decide the maximum they are willing to pay for the program or benefit. There are a lot of inconsistencies in the willingness to pay literature that make it difficult to translate results for use in policy making, including the elicitation method, the starting point bias, or other issues. Also, knowing willingness to pay for one program does not support a comparison across competing programs, and thus is not useful for a full economic evaluation. The potential for this approach is more theoretical than being a practical tool for decision making. When evaluating interventions for substance use disorders, we can approach the calculation of economic benefits by thinking about intervention impact on healthcare utilization, criminal justice incidents, social services, productivity gains, among many others. The societal costs associated with substance use disorders is significant. Capturing the full range of these costs requires translating individual outcomes, such as ED visits, aggravated assaults, days of incarceration, days in a homeless shelter, days working full or part-time, into dollars. This gives you a reference for all the different areas affected by substance use, documented in the literature and surveys. So here you have physical and mental health services, criminal activity and criminal justice, substance use disorder treatment, social and community services, productivity, and quality of life. Within each of these domains, there are several unique outcomes that can be translated into dollars. There are standard assessment instruments that collect several measures across these 6 domains listed on the resources on the Cherish website. You take outcome units like an ED visit, a day under community supervision, or a group therapy session, and use sources such as reimbursement rates as well as the scientific literature to translate outcome units into dollars. The Cherish Methodology Core led a study reviewing existing sources of monetary conversion factors, also called unit costs or price weights, to value substance use disorder outcomes in dollars. This slide provides some examples of outcomes we can value in dollars. The full list of outcomes and conversion factors are included on the Cherish website. As noted earlier, in a CBA, the costs of treatments or interventions are compared to monetized consequences or outcomes of the program, intervention, or policy, with results calculated as the net social benefits, net present value of benefits minus the costs, or a benefit-cost ratio, benefits divided by costs. But as I mentioned earlier, the net social benefit is preferable because the benefit-cost ratio can be problematic for comparison. Why is the ratio problematic? Well, it stems from what elements are included as costs and what elements are included as economic benefits. For instance, if the economic benefits generated by the intervention include, say, the benefits of improved productivity, and also the averted costs from fewer residential treatment episodes, the benefit-cost ratio will be different than the calculation where the intervention costs factor in averted costs. You can see the different answers in these 2 examples on the slide, where one benefit-cost ratio gives an answer of $2 and the second gives an answer of $2.50. The consensus is it is better to use the net social benefits metric as the primary cost-benefit analysis result. In summary, a cost analysis serves as the foundation for any full economic evaluation, whether cost-benefit analysis, cost-effectiveness analysis, or cost-utility analysis. But it is how we measure the consequences of an intervention that differentiates these economic evaluation approaches. For instance, cost-effectiveness analysis calculates incremental cost per unit of outcome in one intervention relative to alternatives, whereas the cost-benefit analysis calculates the net economic benefits by comparing intervention costs to the monetized clinical and economic outcomes. The societal cost-effectiveness analysis overlaps with cost-benefit analysis, as both consider indirect impacts of an intervention. It is the stakeholder valuation of direct and indirect impacts that ultimately helps determine the best resource allocation decision across competing public health and other social programs.